welcome to Medical Dialogues. I'm Dr. Nandita Mohan, and today I will be taking you all to explore the world of rare diseases. And my topic for today is phenylketonuria. Now, to talk to us in detail about this is joining with me today Dr. Roshan Daniel, who is a medical genetics consultant who's practicing in Trivandrum. So, welcome to Medical Dialogue, sir. It's really a privilege to be having you on board here with us today.
Thank you, Dr. Nandita. Good to be here.
Great. Now, Dr. Roshan, if I may ask, we're talking about this rare disease, phenylketonuria. So, what if you can just explain to our viewers what is the genetic basis of this rare disease and how is it actually inherited?
Yeah. So, phenylketonuria is not a very common disease, but when we take rare diseases in total, it is one of the commoner diseases that we see. So, in phenylketonuria, what happens is that we have all these amino acids, right? These amino acids make up all the proteins. Different amino acids come together to make all the proteins in our body. So, these amino acids, one of these is the phenylalanine, and we have a particular enzyme in our body called PAH or phenylalanine hydroxylase. So it is very important for us as this particular enzyme. It converts the phenylketones, this phenylalanine into tyrosine. So what happens is that in this particular condition in PKU, this particular gene or the PAH gene is mutated. So this PAH gene leads to the protein, right? So if the PAH gene is mutated, the PAH does not have its adequate function, and this phenylalanine is no longer able to get converted into tyrosine. So what happens is that this phenylalanine gets accumulated in the body, and it gets turned into many other of its metabolites, which are actually harmful to the body. So although tyrosine is not being produced, that is not much of an issue here. It is the accumulation of the phenylalanine metabolites that is causing. It gets accumulated in the brain, it gets accumulated in all the organs, especially the brain, and that leads to the different diseases. So that is how phenylalanine works at the genetic level, and it is a recessive disease. So we have dominant diseases and recessive diseases. In the recessive disease, both the parents should be the carrier, and each one of them gives the defective allele to the baby, and the baby or the child gets it. So recessive means it does not usually transfer from a parent to the child, but if one child has it, the siblings might get it. So if one child is affected, it is important to identify it, even not only for that baby itself, but in future also the same couple might have another baby with the same disease. So it is important to identify this early itself and prevent in further pregnancies also.
Okay. Now, we're talking about this in a little bit more detail. What are the earliest clinical signs of untreated PKU in infants, and how is this typically diagnosed through newborn screening?
So what happens is that usually these babies present in the newborn period itself. So in Western countries and in a lot of the private sector, what is happening is that we routinely do the TMS testing, that is tandem mass spectroscopy. What we do is that we take the heel prick of the baby, all the babies who are born, we prick the heel and take one drop of blood, and we run it through a series of tests. So one of these important tests is the TMS test, which can detect phenylalanine, the levels of the phenylalanine. So what happens is that we screen all the babies. These babies are all normal right now; they are just newborns, and we do the testing for all, and we will be able to pick up some of these babies who are currently normal, but they have this phenylketonuria and they have not manifested as any diseases yet. So at this point, we can intervene directly. But in case in our country itself, especially where the newborn screening is not being done, these babies get missed, and what happens is that these babies develop especially neurological symptoms, which means that they stop feeding, they become very lethargic, they can develop seizures and all those things. And even then, if it is not diagnosed, we pick these babies at around 1 year of age. They will have very severe development delay, they will have microcephaly and all those things. So infancy we usually see either with newborn screening, we pick it up, or as having multiple neurological issues, especially seizures and encephalopathy.
Yes. So now we talked about the basis, genetic basis, the inherent causes of it, the clinical signs that one develops, and how diagnosis is done. Now coming to the management aspect of it, do you think that lifelong dietary management is typically involved as a management protocol in PKU cases?
Yeah. So, like I told, in PKU, although an enzyme is deficient and the phenylalanine does not get converted into tyrosine, it is typically the accumulation of phenylalanine and its metabolites that cause the disease. So, a very good way to prevent this is that we prevent it at the source itself. The substrate itself we reduce, which means that we prescribe a diet which is very low in phenylalanine, right? So, because the body does not produce phenylalanine, we get it from the foods. So when we have put the baby on a diet which is deficient in phenylalanine, obviously the phenylalanine and its metabolites gets reduced in the body, and we will be able to control the disease. So the major form of management in PKU is that itself, dietary management, in which things which are high in phenylalanine, like meat, fish, nuts, soya, milk, and forms of dairy, and all those things we'll have to restrict. We do not completely stop it, but they can have it sometimes, because we do not want them to have phenylalanine deficiency also. They have to take it somehow, but we keep on monitoring the levels of this phenylalanine in their blood, so that we know that whatever foods they are having are in moderation and does not cause any increase in the phenylalanine levels. So yeah, so dietary management is the major form of management in such babies, and that is what we usually do.
Now, sir, we talked about the dietary management. So, are there any promising pharmacological treatments also beyond the dietary management, which is the standard protocol? Beyond that, are there any pharmacological interventions that we can go ahead with?
So the thing is that, like I told, this phenyl hydroxylase, the enzyme that is deficient in this particular case, that converts this phenylalanine into tyrosine. And for this step to work properly, we have something as a cofactor. It is called BH4, or tetrahydrobiopterin. So what we can do is that in some cases, whenever the mutation comes, the all mutations are not the same. In some mutations, the enzyme might be completely defective and nothing can be done for that. But in most of the cases, what happens is that a protein or a pH enzyme is produced, but it is defective. So what we do is that we give a synthetic form of tetrahydrobiopterin to them. Our aim is that, okay, so we have an enzyme which is partially functioning, okay, and we need a cofactor for this to get converted into tyrosine. We give more and more of this cofactor, so that the partially effective or the defective protein itself functions to the maximum, and at least a good chunk of the phenylalanine gets converted into tyrosine. We are not tackling the situation at the enzyme level or at the substrate level. We are tackling it at the cofactor level. We are trying to utilize the maximum out of the defective protein, so that we can bring down the disease severity. So now we have something called as the sapropterin. So it is a synthetic form of tetrahydrobiopterin. It is a costly medicine. It is not freely available in India. We have to import it from other countries and all, and it is expensive also. I think it will cost, including the importing cost and everything, it will cost around 4-5 lakhs per month for an infant. So mind you, it's for an infant who is around 5 kg or 3 or 4 kgs. So when the weight increases, we will have to increase the dose accordingly, and it becomes quite expensive for a child who is growing up. So it is an expensive option, currently not freely available in India, but in future we expect that all these becomes more freely available and the condition becomes more treatable.
Great, great. Now we talked about the management also. Now specifically, if I have to talk about the management protocol in a specific group of population, like pregnant women or adolescents. So if phenylketonuria occurs in such populations, how do we go ahead and manage them?
Yeah. So the problem with this phenylketonuria is that the metabolites that gets accumulated, it can cross the placenta. So imagine a pregnant lady who is having phenylketonuria, and all these harmful metabolites are there in the body. Okay, and the baby growing in the womb of this lady, that baby per se does not have phenylketonuria, right? But this phenylalanine metabolites in mother's body can freely cross the placenta and into the baby. It's as if the baby is developing phenylketonuria in utero. Okay, so like we told, this particular metabolites are very harmful for the brain. So it has a very detrimental effect on the growing brain of the baby, and also heart. This gets accumulated in the growing heart of the baby also, and can cause multiple issues. So basically, this is called as maternal PKU syndrome. So in which a poorly managed or poorly managed phenylketonuria mother gives birth to a baby, and the baby, because of the effects of this PKU in the mother, has multiple issues. Usually, we see that the baby, by the time the baby is born itself, the baby will have microcephaly. The baby has will grow up to be have severe intellectual disabilities, and also cardiac issues. All these things we expect in such babies. So that is regarding pregnancy in PKU mothers. So coming to adolescence again, in PKU affected patients, the adolescence is a very a crucial part, because of mainly because of two things. Because many times what happens is that we detect these children when they are very early in their age and the childhood itself, and we start them on the adequate therapy also. Initially, the development and all would be normal, but the subtle changes of the PKU starts manifesting in the adolescent period, especially as behavioral issues. So these children during the adolescence might have hyperactivity, they might have behavioral issues and all those things. That is one thing. And second is that during the first 10 years of life or so, the parents would be highly controlling these children and controlling the diet also. So at this particular point, it is important that the adolescent child himself starts to know that a particular food, because the meat and the dairy and all are favorites for a lot of children. And once they are out into the society, they start stealing this food, or they start sneaking this food and having those, leading to detrimental effects. So it is very important that we start educating these children about the importance of compliance to the diet very early, especially in the adolescent stage, so that even though they might not be very symptomatic right now, they should understand the severity of the disease, and we have to educate them to be self-reliant on managing the diet. So that is why the adolescence is also a very important period for these children.
Yes. Now, so you were talking about a cofactors, that is BH4. So, what role does that and the gene therapy combined together they play in the current treatment protocols that have been set out for the management of phenylketonuria?
Yes, gene therapy is still not very not approved or not being used very widely in case of PKUs. So in gene therapy, you might know. So what we do is that we take a viral vector, we introduce the normal copy of the gene into it, and we introduce that particular virus into the body of the person who is affected. So in this particular case, since the enzyme is very important, the liver, we try to introduce this particular virus into the liver. And like all viruses do, the virus would try to infiltrate all the cells which are nearby, and our goal is that this particular virus would enter into all the cells in the liver, introduce the copy of the normal gene into their cells, and they start producing the normal protein. But currently, it is all in the research phase and trial phase only, and we do not have active gene therapies happening around us. But again, combination with saprotidine, again, it is only a theoretical phase right now. We expect that this, in combined with the tetrahydrobiopterin, would be the standard management in the coming years, but we are not yet there. A lot of promising animal trials have already happened, but we are waiting for them to enter into the phase 3 trials and have some results.
Okay, so now we're talking about gene therapy. You laid emphasis on a little bit of promise that it gives us in the for the future. So, what according to you are the latest advancements in this gene therapy or even enzyme replacement therapies for PKU patients?
So much more common, much more easily accessible, although it is not currently in India. But even before gene therapy, what we expect is going to come is the enzyme replacement therapy in India. The ERT, we already know that many of the ERTs are already approved for other genetic diseases and are available in India also. Recently, FDA has approved enzyme therapy for this also, for PKU also. It's called Pegvaliase. So it is available in the western countries currently. No, I don't think anybody in India is currently receiving it, but it should be soon available, because now the Indian government is also emphasizing on rare diseases. They have the national rare disease policy, in which they are willing to give up to around 50 lakhs per child with rare diseases. So with this, we expect that these enzymes would also reach Indian shores, and we'll be able to start in our babies also. This would be a much more practical act with the current scenario and with the current technological advancements, especially in India. I think this would be a better step, or a much closer step to us in managing than the enzyme replacement therapy. So, like the name suggests, it's an enzyme replacement therapy. The whole point of, or the whole problem in PK is that we have this pH enzyme which is deficient or which is defective, and we can replace it somehow. Obviously, that takes away the problem. So enzyme replacement therapy, once it gets approved in India and gets included in the national rare disease policy, many of the children might be able to afford it, and might be affected, or might find fruit from the enzyme replacement therapy.
Yes, definitely. Hopefully, it gives us a promise in the near future as well. Now, also, if I may ask, how is CRISPR being explored for the potential PKU correction? If you can just little bit highlight on that.
Yeah, CRISPR again would be at a stage which is proximal to the gene therapy thing. So, like I told earlier, what CRISPR does is it is basically a gene editing tool. So, the problem with, because since it is a genetic disease, so the first instinct of any person would be to go into the cell and correct the gene, right? But why are we not able to do it? We are not able to do it because there is not enough tools in which can do something called as site targeted mutagenesis, which means that we don't have a very good technology to go to send something to go to a particular position in the genome and correct that. So this was extremely difficult before 2010 or 2012, when CRISPR-Cas9 got its attention. Before that, all the mutagenesis was random and chemically mediated, very cumbersome to do, and all those things. But once CRISPR was introduced, we had something in which we could target a particular area, and we could introduce mutations, or we could change the base pairs in that particular area. So that is what the revolution that CRISPR had fought. So again, if you think about it, what is its role? What it would do is that, like we told, in many of these vectors, viral vectors, we take a normal copy of the gene and put it inside. Another way to do it is that we take the cells or the genome of the patient who is affected, and we introduce a particular mutation with CRISPR. For example, there is a mutation of a G to A in a particular position. We can use the CRISPR to turn it back into the G in the patient's own cell, and then we introduce it back. So the aim is that we would be able to take some stem cells out of a patient himself, and we would change the mutation or the particular base that is affected. We would convert it back into the normal, and we would introduce it back into the body. And since these are stem cells, they would differentiate back into the affected tissue, and it will be able to cure the disease. So in this particular case, most probably liver cells, we would be engineering like that. Again, this would play a part which is prior to a gene therapy. It again, in the research phase only, nothing concrete has come up from that yet. But in the next decade or so, we expect that most of the genetic diseases would have some sort of CRISPR mediated and viral mediated gene therapies, which would be able to cure or at least control diseases to a great extent. So that is the role of CRISPR in PKU, and also in rare genetic disorders in general. That is how the research is progressing currently.
Okay, lastly, Dr. Roshan, you talked about newborn screening programs. Do you think these are effective in detecting PKU on a global platform? Are these screening programs essential, and should they be carried out on a regular basis for early diagnosis?
Correct, correct. That is without doubt. It has to be done, because why? What is the whole point of newborn screening? We know that the baby is normal currently, and we find out that the baby is going to have some disease or develop some disease in the near future, and we are able to prevent it. So any such disease warrants a newborn screening. If we talk about hypothyroidism, congenital hypothyroidism, it is not a genetic disease per se, but that also we are doing a newborn screening. Why? Because if we don't, the baby is normal now. Okay, if we don't detect it now, the baby is going to have severe neurological deficits. But if we find out now, we can start a simple tablet or the thyronome or the thyroxine tablet, and the baby would be normal for life. So that is the power of newborn screening. When we talk about phenylketonuria and IEMs in general, especially amino acidopathies and organic acidemias, the baby is normal right now. If we don't detect it right now, baby is going to develop severe neurological disease. But if we find now, we have effective dietary treatments and pharmacological treatments which can take the make the baby normal, keep the baby normal. So the stakes are very high at this question. If it is a disease which does not have a treatment, okay, we don't need a newborn screen. There is no, if it is a disease which we can't do anything, even if we find, then that is fine. And if it is a disease, it is a mild disease, okay, that also is fine. We don't need to do a newborn screen. But being a disease which has devastating consequences if it is not detected well in time, and the management is very easy with diet, okay, we should not miss such diseases. So currently we do not have any way to reverse the neurological effects of such diseases. Currently we do not have any method of curing like gene therapy or anything is not yet such a scenario. There is no doubt it is the way to go forward. Newborn screening, especially in such cases, organic acidemias and amino acidopathies like PQS, is surely recommended and has to be universally adopted. Yeah.
Great. So, thank you so much, Dr. Roshan, for joining us today at Medical Dialogues and giving us all your valuable insights on the diagnosis and the early management of phenylketonuria. Definitely, it's a rare disease, and we all have to come down to understand the importance of early diagnosis, starting from the newborn screening protocols and then going way ahead to its management. So, thank you so much once again for joining us at Medical Dialogues today.
Thank you, Dr. Nandita and Medical Dialogues for having me. Thank you.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.